Welcome to EJournal Club. This is Dr. Leonard Calabrese from the Cleveland Clinic Foundation, coming to you with another edition of our EJournal Club that explores articles in the area of basic and translational immunology, clinical rheumatology, right from the literature to your desktop. So truth-telling is that I pick these articles, and I pick the ones that are of greatest interest to me, and certainly the area of IgG4-related disease is one of those areas. And we're really fortunate to have Dr. John Stone from the Massachusetts General Hospital, who's really been a pioneering force in this IgG4 area. So welcome, John.
Thanks very much, Lynn. I am really delighted to be here today to talk about some work from my group, which was published very recently in Annals of the Rheumatic Disease. And the title of the paper is The Diagnostic Utility of Serum IgG4 Concentrations in IgG4-related disease. Let me start by giving you a little bit of background. No one had really heard of IgG4-related disease until this century. So less than 15 years or so ago. But the Japanese really were the first to become aware of this. And there was a seminal paper published in the New England Journal of Medicine in 2001. And that was entitled High Serum IgG4 Concentrations in Patients with Sclerosing Pancreatitis. And this paper called attention to the fact that serum IgG4 concentrations differentiated sclerosing pancreatitis from a variety of other hepatobiliary conditions. Now, we now call sclerosing pancreatitis type 1 IgG4-related autoimmune pancreatitis. But at that time, no one had made the connection. It wasn't long after this paper that other Japanese investigators recognized that patients with sclerosing pancreatitis also had extrapancreatic manifestations of the disease, and the pathology in those extrapancreatic organs looked just like the pancreas. Now, the Japanese coined a very interesting metaphor for this condition, and that is they have likened the disease to a crow flying through the dark night of medical history. And over the last 12 to 15 years, this crow has come into full light, and it's now recognized that the disease not only involves the pancreas, but literally just about every other organ. The brain parenchyma and skeletal muscle are really about the only two organs I can think of that are have not been shown to be affected by this disease, but it can involve just about everything else. And the pathology is quite distinctive. So this slide shows a biopsy of autoimmune pancreatitis. In the center of the slide is the pancreatic duct. It's surrounded by a lymphoplasmacytic infiltrate. And one of the main characteristics of the pathology is this swirling fibrosis, which really goes throughout the tissue here depicted on this slide. Pathologists refer to this as storiform fibrosis. The next slide shows a CT scan of a patient with autoimmune pancreatitis, what the Japanese called sclerosing pancreatitis. The pancreas in the center of the image is large, sausage-shaped, and it's lost its normal pancreatic markings. And this is an image to illustrate the diversity of organ involvement of hypertrophic pachymeningitis caused by IgG4-related disease. These are MRI scans of 4 different patients with IgG4-related hypertrophic pachymeningitis. Very diverse tissues, the pancreas and the meninges, the dura mater. But the biopsies from both of these organs, and indeed from all of the organs affected by this condition, show the same thing. So the the slide following the meningeal MRI images shows this pathology again. And there's a lymphoplasmacytic infiltrate. It's important to note that immunostaining of these cells shows that a high percentage of the plasma cells are IgG4 positive. Again, throughout the slide, one can see storiform fibrosis. And nearly in the center of the slide, one has to be a very good pathologist, actually, to recognize that this was a vein. And this vein has undergone the process of obliterative phlebitis. So these are the three main pathology hallmarks of the disease: lymphoplasmacytic infiltrate with a high percentage of plasma cell staining for IgG4, storiform fibrosis, and obliterative phlebitis. I harp on the pathology because at the end of the day, as the paper will illustrate, pathology really remains the gold standard. The next slide shows retroperitoneal fibrosis, a very interesting subset of IgG4-related disease. The retroperitoneal fibrosis surrounds the aorta, as it often does. One can see in this cross-sectional image of the abdomen that the patient has a stent in the right ureter because the patient had developed hydronephrosis. And this next slide illustrates, again, this phenomenon of obliterative phlebitis. I have outlined the vein in the arrows, but without the arrows, I think it would be very difficult to appreciate that the inflammatory process has moved right through the vein and destroyed, obliterated lumen and destroyed the walls. Sometimes an elastin stain, as shown on the following slide, is needed to illustrate and demonstrate obliterative phlebitis. In this slide, the artery is coursing close to the vein, as they typically do, and you can see that the artery has a nice, intact internal elastic lamina. In contrast, the internal elastic lamina of the vein has been destroyed, and the elastin stain illustrates that nicely. This is what the disease looks like in the lung. In the lung, the disease tends to track along the bronchovascular bundle. So wherever you see an airway in this wedge resection of the lung, you also see a whitish globule, which is what the gross pathology of IgG4-related disease looks like. And then the histology slide of this lung, again, shows the airway, but the cardinal features, again, of lymphoplasmacytic infiltrate, storiform fibrosis, and obliterative phlebitis. Now, let me hasten to add, since the topic of this paper was IgG4, and serum IgG4 concentrations were really the way that this disease came to medical attention back in 2001. Let me emphasize that IgG4 itself is unlikely to be pathogenic in this disease. All IgG subclasses are not alike. IgG4 is normally the least abundant of the four IgG subclasses, and it is different from the other subclasses. So depicted in this slide are two typical, prototypical immunoglobulins. But IgG4 is different in that in solution it undergoes a process called FAB arm exchange. It literally becomes unhinged in its hinge region and undergoes a swap, a half antibody exchange, such that the FAB arms of the recombined antibodies are different. And the consequence of that is that IgG4 normally does not bind antigen tightly because it can only bind to a single antigen with one FAB arm. The upshot of that is that IgG4 doesn't activate the classical complement pathway. It binds to other immunoglobulins only weakly. And it has really always been thought to be a downregulatory antibody, an anti-inflammatory molecule, we really view this antibody as serving as an antigen sink in this disease, probably a secondary phenomenon trying to soak up the antigen and downregulate the immune response, the primary immune response. A lot of that remains to be sorted out, but that's our current thinking. So on to the paper now. Serum IgG4 concentrations have been emphasized in this disease ever since 2001, and I think they probably had too much emphasis placed on them. They are a biomarker of some use, but they have their shortcomings, and that's why we undertook this study. So between 2001 and 2011 at our institution, 190 different patients were found to have elevated serum IgG4 concentrations. And as part of the study, we reviewed the electronic medical record of these patients to determine why they underwent IgG4 measurement and, as far as possible, to determine the underlying clinical diagnosis. Then for comparison, from a pool of more than 3,300 patients who had normal results during this time, we randomly selected 190 of the patients to serve as the comparison group to evaluate the test characteristics of the IgG4 measurement. The next slide shows the diversity of diseases that are associated with elevated serum IgG4. And in short, there are a lot of different diagnoses that can be associated with a substantial elevation of IgG4. And these are listed along the x-axis on this graph. The normal serum IgG4 concentration in our laboratory is on the order of 135 milligrams per deciliter. The assay has changed a little bit over the years, but it's on that order. So one sees that a serum concentration of 500 or 1,000 or 1,500 really represents a very marked elevation in the concentration of IgG4. And there are a whole lot of different disorders that can be associated with that. It should be said that our ability to know the precise diagnosis in all of these patients retrospectively was imperfect. So I can't help but wonder, for example, whether these three patients with aortitis who had substantial elevations in their serum IgG4 concentrations really had IgG4-related disease. But that's the challenge of doing a study in retrospect. Table 3 from the paper then shows the mean serum IgG4 levels in these different diseases. And this table, again, makes the point that a great diversity of different diagnoses can be associated with elevations in serum IgG4 concentration. So an elevated serum IgG4 concentration in and of itself certainly does not make a diagnosis of IgG4-related disease. Now, with regard to sensitivity of IgG4 in this study, in the total 390 patients analyzed, we judged that 72 of these had either probable or definite being biopsy-proved with close clinical pathological correlation, IgG4-related disease. And 65 out of those 72 with either probable or definite IgG4-related disease had elevations in their serum IgG4. The mean elevation in those patients was 405 milligrams per deciliter. So this leads to a sensitivity for serum IgG4 assays in this study of 90%, which sounds pretty good. With regard to specificity, however, it's not surprising, given the diversity of different diseases that I showed you in previous slides that can be associated with an elevated serum IgG4. It's not surprising to find that the specificity is a bit lower. And indeed, in this study, the specificity of serum IgG4 concentration elevation was only 60%. The negative and positive predictive values also diverged substantially, even more so. The negative predictive value of a serum IgG4 in this study was excellent, was 96%. However, the positive predictive value, again, reflecting the range of disorders that can be associated with IgG4 elevations, the positive predictive value was only 34%. So we took a look at a variety of other ways of examining the serum IgG4 data. One of the points that has been discussed in the literature is that the ratio of serum IgG4 to total IgG may be a useful biomarker or indicator of the diagnosis of IgG4-related disease. And the numbers that have been used in the literature are a ratio of greater than 7 or 8% of the total IgG being IgG4. However, we did not find this to be the case in our study. We did not find the serum ratio of serum IgG4 to total IgG was more useful than serum IgG4 alone. We then doubled the cutoff for the upper limit of normal of IgG4, and we found that the specificity, which had been only 60%, improved to 91% with a doubling of the cutoff of the upper limit of normal. But unfortunately, that doubling led to a decrease in the sensitivity to only 35%, which I think we would all agree is probably unacceptably low. So Table 2 then summarizes the test characteristics of the different assays and ways that we looked at the serum IgG4. And it summarizes these findings well. In short, it really seems that the cutoff of about 135 milligrams per deciliter with the assay that we used in our hospital achieved very reasonable, probably optimal test characteristics for serum IgG4 in this disease. Now, a very important point comes from another study from our group, which is currently in press at Arthritis and Rheumatology. And this study examined 125 patients from our center who had biopsy-proven IgG4-related disease. So it's a slightly different population than those studied in the Annals of Rheumatic Diseases paper. And in that study, which required biopsy proof of the diagnosis, only 55% of the patients had elevated serum IgG4 concentrations before they started treatment. And I think that is a very striking finding, and it illustrates that the conclusions one makes about the utility of serum IgG4 are really based, not surprisingly, on how one chooses one's patients. If you insist on biopsy proof of the diagnosis, then you find that the sensitivity of a serum IgG4 assay is really substantially lower than if biopsy proof of the diagnosis is not required. So in conclusion from these papers, there are multiple non-IgG4-related disease conditions that can be associated with an elevated serum IgG4. So the specificity and the positive predictive value of this test are rather low, even though it's associated with a reasonable sensitivity. A substantial subset of patients with IgG4-related disease, with biopsy-proven IgG4-related disease, don't have elevated serum IgG4. And just how big that subset is depends on how one defines the disease. And finally, we also found that neither doubling the cutoff for serum IgG4 nor examining the serum IgG4 to total IgG ratio improves the overall test characteristics for the diagnosis of IgG4-related disease. So if I could sum up just in one sentence what I think about making the diagnosis of IgG4-related disease is these days, I cannot think of another disease where more careful clinical pathological correlation is required to establish the disease. And invariably, it is really important to sit down at the microscope oneself and go over the case with the pathologist to compare notes to arrive at the right diagnosis. Thanks very much.
Excellent, John. I appreciate it very much. So, a couple of observations. First of all, I think this is, these are important pebbles on the pile here in the understanding of this disease. And at first blush, I was very impressed with a 90% sensitivity. And I think that you're throwing in your observation from your other article in Press really, balances that. That depends on how you identify patients will greatly influence, the receiver operating characteristics of these tests. So let me ask you just philosophically, and we'll turn to retroperitoneal fibrosis because it's a disease that we've been interested in for a long time. So if you have all of these patients that have biopsy-proven IgG4 and basically half of them have normal levels of IgG4 at pre-treatment. So you're implying that this antibody marker, which you clearly stated that you didn't have strong belief was a driving immunopathogenic force, it suggests that there's a transient nature of this serum marker. How do you feel about the enduring nature of IgG4 bearing plasma cells in the tissue of patients who have had this? Is it something that is more likely to be encountered at day one versus someone who's had retroperitoneal fibrosis for 5 years and silently growing and then looked at down the line? What's your gut feeling and what's your experience?
Oh, that's a great point. And retroperitoneal fibrosis is probably the most challenging subset of IgG4-related disease for a number of reasons. One of them is establishing the diagnosis. And it makes sense that retroperitoneal fibrosis is subclinical for a long period of time in many patients. And by the time it is diagnosed, very often it is overwhelmingly fibrotic. And on biopsy, in many patients, one really just sees mostly fibrosis. And there are far fewer, the lymphoplasms that it can infiltrate in many of these patients is substantially less. So if one is counting IgG4 positive plasma cells in tissue, the number of those may be relatively small. In tissue, the ratio of IgG4 positive plasma cells to total plasma cells may be very useful in that setting. But at the end of the day, really, the histopathology is really more important than the immunostaining. So the finding of the characteristic storiform fibrosis and the obliterative phlebitis, those are really very telltale signs. And an astute pathologist working with an astute clinician can usually establish the diagnosis together. But retroperitoneal fibrosis is challenging, both in terms of making the diagnosis and attributing it to IgG4-related disease sometimes, and, of course, in treatment because of the overwhelming fibrosis that so many of these patients have.
Another finding in your paper that caught my eye, and I probably hadn't thought about it this much, was a effect of sex on these levels, this differential effect that in the high IgG4 group as a whole, it's a male predominant type of finding. I mean, at least shifted compared to the normal level. Has that been identified before?
That is another interesting observation, and you're absolutely right. IgG4-related disease does have a male predominance, and it's anywhere from 60 to 80%, depending on the organ involved. In our overall series that I talked about of 125 biopsy-proven patients, only 60% of the patients were male. But there's certainly other series in the literature where the male dominance is more striking. Having said that, we looked compared in our series of 125 patients for differences in disease severity and in disease extent and in serum IgG4 concentration elevations between males and females. And we really found that there were not significant differences in the disease expression between the genders. And I was surprised by that. I thought we were going to see that males had more severe disease, were more likely to have multi-organ involvement, and very elevated serum IgG4. But that's not what we found. So there seems to be clearly a male predominance in the disease, but it's not clear that it is more severe in males than it is in females.
Well, let me close with an observation and a final question. So, interestingly, there was a nice paper by the rheumatology group at the Peking Union Medical College Hospital earlier this year in medicine, who looked at all immunoglobulin subclasses and a sizable number of patients with well-documented connective tissue disease. And consistent with your findings, only a few percent had elevated IgG4, which is comforting in terms of specificity determinations. And so my final question to you is a selfish one. So, John, in this retroperitoneal fibrosis world, if you have a patient who is biopsied, who has classical IgG4 disease in terms of histopathology and IgG4 staining and IgG, and you have another patient who has just fibrotic disease without clear histologic criteria and no IgG4, does that influence the way you treat them?
Well, that's an area of ongoing work. And I can tell you anecdotally that I have had some good success treating patients with what seem to be fairly fibrotic disease on biopsy. I've had good success treating some of them with steroids and with B-cell depletion. Part of that may relate to sampling error. Most of the time when we biopsy the retroperitoneum, we do a CT-guided needle biopsy, very small tissue. So what one gets could be distinctly unrepresentative of the rest of the tissue. There are relatively few treatment options for these patients, and I think the pain that these patients have and the hydronephrosis and the concern about aortic damage that they can get really does justify being moderately aggressive in them. And so it's probably worth treating them all alike, at least at first. And if they fail to respond, then I think you have your answer, and we need to continue looking for other treatments that are directed at more at the fibrotic end than the inflammatory end.
Well, I agree with that 100%. Makes me feel better. So, listen, this has been Dr. John Stone reviewing a very nice article that has added to our understanding of IgG4. We appreciate all of you who are listening in with us. Please come back and look at the other Journal Club articles that we're doing this year. They're all high impact, high interest, and come back to our website time and time again. So, John, thanks again, and we appreciate your participation.